wound healing is an important process of surgeon's armamentarium. What you do is to facilitate the body to heal itself. So whatever we do, we have to do it in such a way that you help and facilitate the body to heal. So though it appears to be a very boring subject, I think it is very important and very vital. I think we should all concentrate, not because it comes in the examination, which it will, but as we keep telling you, our aim is to prepare you for life, to become good surgeons, and examination is an interlude which you will all pass. Maybe hopefully first time, otherwise you will pass ultimately. So I don't think you need to worry too much about examination. You need to prepare for life, for you to become good surgeons, treat your patients well. So wound healing is an important chapter, and I tried to see if we could get even the plastic surgeon Dr. Aditya Patil for this, but he is on leave, so I don't think he could come because of that. So anyway, Praveen is going to this is his first class. I think going through his presentation, he's prepared it well. So let us see how he talks. Okay, over to you, Praveen. All the best.
Yes, sir. Hello. Good evening to respected teachers, my dear colleagues and seniors. Today's topic is wound healing. And today's plan of talk is introduction of skin and wound, phases of wound healing, factors influencing wound healing, classification of wounds, and treatment of wounds. Anatomy of skin. Skin is mainly made up of three layers: epidermis, dermis, hypodermis. And the whole process of wound healing occurs in the dermis and hypodermis, which has abundant collagen bundles. Wound. What is a wound? It is a breakdown in protective function of skin, loss of continuity of epithelium with or without loss of underlying connective tissue following an injury. What are the phases of wound healing? It is mainly divided into three phases, but actually all the three phases is overlapped. And those are hemostasis and inflammation, proliferation, maturation and remodeling. Hemostasis and inflammation. Hemostasis. It is the first step which occurs immediately after wound and it lasts for 2 to 3 days. Hemostasis initiates and it precedes and initiates inflammation so that all the chemotactic factors accumulates at the wound site. When wound occurs, there is a disruption in tissue integrity which leads to exposure of blood vessels and extracellular matrix to platelets. When platelets are exposed to subendothelial collagen, platelets get activated and results in platelet aggregation, degranulation, and activation of coagulation cascade. In point of surgery, what is the importance of this coagulation cascade? When there is damage to endothelial tissue, the extrinsic pathway activates and finally results in the formation of stable fibrin clot. And clinically, we can measure this by prothrombin time. Prothrombin time measures the factor 1, 2, 5, 7, and 10. Why prothrombin time is essential? Because when patient is on anticoagulants and antiplatelet drugs, and if there is any liver damage and patient is suffering from vitamin K deficiency, then this extrinsic pathway and common pathway prolongation occurs and there will be delay in clot formation.
Go back. Pavan?
Yes, sir.
Have you understood the coagulation cascade pathway?
Yes, sir.
So Praveen told us about the prothrombin time being the measure of the extrinsic pathway. What is the measure of intrinsic pathway?
Sir, APTVT, sir.
What is that?
Sir, that is activated partial prothrombin
Thromboplastin time.
thromboplastin time, sir.
So what is the normal APTT?
Sir, less than 30, sir.
No. You can't say, it's a range.
Okay.
Indraja?
24 to 30, sir.
Slightly away.
Yes.
Let us. Has Abdul joined the class?
No, sir. No.
He's not yet joined.
No, sir.
Okay. Is Vinod there in the class?
No, sir. We know this not.
Okay. Pooja, will you be able to say what is the normal APTT?
Sir, 20 to 35, sir.
28 to 34. Yes. 28 to 34 seconds. So I think that will see how tell us how well the intrinsic pathway is working, and prothrombin time will tell us how well the extrinsic pathway is working. Okay, so I think why this is important is as soon as there is injury, there will be exposure of the tissue. See, the blood is flowing normally because of the fact that there is no exposure of the coagulation factors to a disrupted endothelium. Moment there is that, then there will be the coagulation pathway gets activated because of the tissue thromboplastin factor, and because of that the platelets aggregate, and then platelets will release the coagulation cascade. It will help to release the coagulation cascade so that the body will plug the disruption in the endothelium and also wherever there is bleeding. So that is how it works. And I think this is very good because I have to congratulate Praveen for having brought this up, because usually in wound healing, this part is not actually brought. Okay, carry on, Praveen.
Yes, sir. After formation of fibrin clot, bleeding gradually stops.
No, go
And
back to the previous
sir,
slide. You explained this slide. Yes. It is important for you to explain this slide.
So it's the same procedure of coagulation cascade, sir. Fibrinogen is converted into fibrin and it forms a fibrin strands, and it plugs the RBCs and forms a clot, insoluble clot.
Okay. So fibrinogen becomes fibrin, and then the clot stabilizing happens, and that will form the plug of wherever there is disruption of the blood vessel. Okay.
Yes, sir. And when the bleeding stops gradually, platelet contains alpha granules, which releases many cytokines such as platelet-derived growth factor, transforming growth factor beta, platelet activating factor, fibronectin, thrombospondin. And platelets and locally injured tissue releases many vasoactive amines such as histamine, serotonin, prostaglandin, which increases the vascular permeability, and it allows the infiltration of inflammatory cells. Here we can look at
you have to remember this very important. Platelet not only is concerned with formation of the clot, but it also is very important as far as inflammation is concerned. Okay. Carry on.
And we can see here the inflammatory cells that includes neutrophils, macrophages, lymphocytes. Polymorphonuclear leukocytes. It is the first cells to infiltrate at the wound site, which peaks around 24 to 48 hours. The importance of PMNs are, it is a major source of cytokines, TNF alpha, in early inflammation, and it also stimulates the angiogenesis and collagen synthesis. It also releases proteases such as collagenases, which participate in the matrix formation and ground substance degradation in early part of wound healing. Macrophages. These are derived from the circulating monocytes. They increase at 48 to 96 hours post-injury and present until wound healing is complete. The functions of macrophages are: it helps in angiogenesis by stimulating growth factors, and it helps in cell recruitment and activation, and helps in matrix synthesis regulation and wound debridement by phagocytosis and enzymes such as collagenase elastase. Antimicrobial function by releasing oxygen radicals such as hydrogen peroxide, superoxide oxygen, OH radicals, and nitric oxide. And it also stimulates growth factors such as platelet-derived growth factor, transforming growth factor beta, endothelial growth factor, and intrinsic growth factor. Next, T lymphocytes activates and it peaks at 1 week post-injury, and it bridges a transition from the inflammatory to the next phase of proliferation. And 5 cardinal signs of inflammation are dolor, calor, rubor, tumor, and functional assay. And why this dolor occurs? It is because the movement of blood passes through the dilated vessels into the environmentally cooled extremities. So heat is because of more amount of blood is passed through the vessels, heat is produced. And due to increased number of erythrocytes passing to that area, redness occurs. That is rubor. And due to permeability and dilated vessels, passage of fluid occurs into the surrounding tissue, so edema occurs. It is seen as tumor. And due to direct effect of cytokine mediators, and due to inflammatory response, and due to stretch of sensory nerves during the injury, pain occurs. And due to edema, pain, and scar tissue formation, there is loss of function. And these are the 5 cardinal signs of inflammation. Next, second stage is proliferation. It is second phase of healing, which lasts around 4 to 12 days, and during which tissue continuity is re-established. During this phase, fibroblasts carry out matrix synthesis by producing collagen. Endothelial cells.
Ravi,
Sir?
1 second. I think Ravi Shankar sir is logged out.
Yes, sir.
Can one of you just call him? Just hold on till he just logs in now.
Yes, sir.
Okay, sir. Will call.
Can you just go 1 or 2 slides back, Praveen? I think I just missed that slide. Back. Okay. Done. Go back to your slide on. Yeah, next one. Were you able to call Ravi Shankar sir? He's back.
Yes, sir. Can I continue, sir?
Sir, he has asked us to continue. There's some problem with the audio, it seems, sir.
Okay.
That is why, which is why he had logged out.
Sure, sir. Yeah, carry on.
Yes, sir. And second phase of healing is proliferation, which lasts around 4 to 12 days, during which tissue continuity is re-established. During this phase, fibroblasts carry out matrix synthesis and produces collagen. Endothelial cells proliferate extensively, and they migrate to the wound site and participate in angiogenesis. And wound tissue formed in this earliest part of phase is known as granulation tissue. In later part of this phase, there is increase in tensile strength because of increased collagen, which is mainly of type 3, but it is deposited randomly. And third and final stage is maturation and remodeling. This phase is characterized by maturation of collagen type 1, which replaces type 3 until a ratio 4:1 is achieved. As I said initially, During the proliferation phase, collagen are aligned haphazardly, but during the maturation remodeling phase, collagen fibers are aligned along the lines of tension. Deposition of matrix follows a certain characteristic pattern. In early matrix, it consists of fibronectin and collagen type 3. In intermediate, it consists of glycosaminoglycans and proteoglycans. And in the final matrix, it is preceded by collagen type 1. Maturation of collagen increases the tensile strength, which is maximum at 12th week post-injury and represents approximately up to 80% of normal skin. And scar remodeling continues for many months, approximately 6 to 12 months post-injury, which results in mature avascular and acellular scar. Epithelialization. It is a final step in the wound healing, which is characterized by proliferation and migration of epithelial cells adjacent to the wound towards the wound site. Normally, reepithelialization is completed in less than 48 hours, but when there is significant epidermal or dermal defect, it takes longer time. And to summarize this, here you can see all these three phases are overlapped. And coming to gastrointestinal tract,
Praveen,
healing, sir.
Stop. Basically, anybody has any questions?
Sir, regarding this epithelial migration, is it the same as that fibrin sealing which happens at the wound edge, sir?
Hello, Praveen, do you want to take that
Sir?
question?
No, sir. I don't have idea, sir.
Nishant, I didn't get your question.
Sir, after a clean incised wound, when we approximate the skin edges, there is a fibrin sealing which happens. That is the reason we leave the wound open, sir. We don't ask them to use a dressing and all because that sealing would have happened.
Yeah.
I wanted to know, is it the same as epithelialization or different?
I think it is the same. It
Okay.
as he said, it happens about 48 to 72 hours. That is why you keep the wound dressing on for about 2 days, and then you can take it off because the epithelialization would have happened and it would have sealed.
Yes, sir. Thank you, sir.
Praveen,
Yes, sir.
you talked about collagen, type 3 collagen being replaced by type 1 collagen.
Yes, sir.
So can you give me another example of where this is now considered to be the most important factor in the formation of a particular sort of pathology which we operate on very regularly? Anybody?
Goodpasture syndrome, sir.
No.
Regularly.
Don't go very complex.
Yes, sir.
Pawan, can you answer that question?
Sir, I didn't get that question, sir, actually.
See, previously there were lots of factors ascribed to the what shall we say, pathogenesis of this particular condition which we operate on very regularly. It's a very common condition that we operate. One of the most common operations a surgeon does. But recently
Hello, sir.
So now we have found that these collagen fibers are the main reason for the formation of this particular condition. What do you think I'm talking about? I think I've given you enough clues.
Pawan, what are the
Sir,
common surgeries you do, Pawan?
Indraja?
No, sir.
Sir,
Huh? Pooja?
Don't know, sir.
Pooja also doesn't know?
No, sir.
See, this is why I think that Lakshman sir and myself and all of us, we keep telling you, you should always apply your knowledge elsewhere also. Because, when you are talking about this, you should think, laterally. So basically, previously, when we thought of hernias, we used to think it is due to chronic constipation, excessive coughing due to COPD and bronchial asthma and chronic bronchitis and urethral strictures and prostatic enlargement, which causes the secondary causes for hernias. But that the theory has been debunked now. Basically, it is the excessive proliferation of type 3 collagen fibers in patients who develop hernia, as opposed to type 1, which is the stronger and the more mature collagen. So that is the reason why people who have this, and when they have these, they are the precipitating factors. They are not the cause for the hernia, but the precipitating factors happen, then these people develop hernias. You understand, no? So I think it is just an extension of this wound healing concept, where type 1 collagen is what you need, but type 3 collagen, if there is proliferation of that, it is weak, and hence it allows the body to develop hernias. And usually this is ascribed to the formation, obviously, of direct inguinal hernias, because direct hernias is due to the weakness of the posterior wall, right? All of you understood?
Yes, sir.
Yes, sir.
Okay, carry on.
Coming to gastrointestinal tract, healing of full thickness gastrointestinal tract wounds begins when there is surgical or mechanical reapposition of bowel ends. Wound healing has two sides. If there is failure of healing, it results in dehiscence, leaks, and fistulas. If there is also excessive healing, it also results in stricture formation and stenosis of lumen, which are significant in both morbidity and mortality. The early integrity of anastomosis is dependent mainly on the formation of fibrin cell on the serosal side, that is outer layer, and suture holding capacity of intestinal wall. Submucosal layer, it has the greatest tensile strength and it has the greatest suture holding capacity. And serosal healing is essential for quickly achieving watertight seal from lumen side of the bowel. Otherwise, there are high rates of anastomotic failure in the segments of bowel that are extraperitoneal and lack serosa, which are esophagus and rectum.
Okay, Pavan, what is the significance of what he just told you?
Sir,
What is the significance of what he just told you? So whenever you are anastomosing, what are the 3 things you need to worry about?
sir, one is a type of whether it is hand sewn or stapler when we are using. And
that is okay. I think that is not, though there is one study, especially for the large bowel anastomosis, that staple anastomosis is considered better than hand-sewn anastomosis, but that is not what I was talking about. What are the 3 important features that will ensure that your anastomosis stays sound?
Sir, there is no tension present in the anastomosis.
Yeah.
Adequate vascularity should be there.
Yes.
And
what is the third one?
Sir, we have to leave that mucosa, and inversion of mucosa should be there, sir.
Technique. So basically, it is a technique which which ensures the anastomosis is good. So though you can't perform randomized control trials, or there are not many randomized control trials, if you look at cross-sectional studies that have been done, it shows that the single layer sub-zero muscular interrupted anastomosis seems to have the best outcomes compared to other types of anastomosis, which is 2-layered anastomosis and things like that. The reason for that is that with sub-zero muscular interrupted sutures, You take every bite under direct vision. You obviously take the submucosa because that is the layer which affords the highest tensile strength, and you exclude the mucosa because mucosa is the layer which is most prone to ischemia. So if, see, for example, mucosal ischemia, what problem that causes is, if there is ischemia of the one portion of the anastomosis, that one, it becomes denatured, it becomes a nidus for infection. So ultimately the anastomosis, because of the infection, anastomosis breaks down. So which is why you should avoid taking the mucosa. So mucosa is prone to ischemia. So if you take mucosa and tighten your anastomosis, then what happens is, if there is localized death of the mucosa, then it can form a nidus from which the infection initially an infection can happen, and then that can lead to anastomotic breakdown at that area. So that is why subseromuscular anastomosis, single layer, is the most preferred method of anastomosis. And again, if you look at the stapled anastomosis, the configuration of the staples is such that it allows the blood flow to the mucosa to happen on a regular basis, because it is kidney shaped and there is a hilum in the middle through which the blood vessel can enter, and hence again the integrity of the anastomosis is retained. You followed?
Yes, sir.
Nishant, anything to add?
Just one point. Like sir said, the single layer is very much preferable now. And what's important for you guys is that you need to know that the anastomosis has to be watertight, not airtight. If it is, you can never have airtight anastomosis with single layer anastomosis. Okay. So just keep that in mind. If you need to have airtight, it has to be continuous. But the whole idea is you need it to be only watertight. So a single layer interrupted is a very much preferred type of technique for anastomosis, which is done now.
Okay, all of you followed?
Yes, sir.
Yes, sir.
Continue.
Yes, sir.
Continue, Praveen.
Yes. And during the formation of collagen, initially there is a initially there will be the breakdown of collagen because of lysis, and due to collagenase, which are derived from the neutrophils, macrophages, and intraluminal bacteria, and gradually collagen production increases. So as a result, there we can see a steep curve which shows a balance of collagen. This integrity of anastomosis represents equilibrium between collagen lysis and collagen synthesis, which takes few days to initiate. For technical considerations,
Praveen,
in order for
if I may, can you just go back to the previous slide? And can you try and tell us what is the practical implication of this particular diagram that you're trying to tell us?
This week period is around 7 to 10 days, and this period is main for dehiscence and leak of fluids. So if there is any collection of fluid, we should expect around these days, sir.
Correct. So
Not collection of fluid, man. Correct.
Sir.
So
See
you expect a leak between 5 to 7 days. So in other words, if I ask you if the patient has a leak on post-op day 1 or post-op day 2, what do you think is the problem? Praveen, you there?
Sir, yes, sir, yes, sir. Mainly intraoperatively
Technique related.
yes,
Okay.
technique related, yes, sir.
If you have not closed it properly, or if you have left a hole, that angle of sorrow and all what we are talking, no, at the mesenteric edge. So these
Yes.
are areas which are blind and sometimes you might miss it. So on day 1 or day 2, if the patient has a leak, it is technique or surgeon related factor. And like you said, that week, the time where 5 to 7 is that you have done your job, but the healing is not up to its expected mark.
Yes, sir.
Thank you, sir.
So normal, anastomotic leak or anastomotic dehiscence happens by between 5 to 7 days up to 10 days, and that is to be expected because of other reasons. But if it happens earlier than that, then as Nishant said, it is due to technical reasons. Another thing you have to understand is, in patients who are very sick and who are septic and who are in ICU needing inotropic support, you have to be extremely careful in doing anastomosis on such people, because if you have done an anastomosis in a septic abdomen, that in itself is a wrong thing. And in addition to that, if these patients are on inotropes, especially norepinephrine and epinephrine, who have significant splanchnic vasoconstriction, your anastomosis is at risk because of that. The blood supply to the anastomosis is decreased. Because of that, even though you have done a good job, the anastomosis is at risk because of lack of vascularity. So you have to take all these things into consideration when you do anastomosis. It's not about being a hero or being technically gifted. Your decision making also comes into play in these kind of situations. Okay.
Yes, sir.
Continue.
Technical considerations to be seen are, in order for an anastomosis to heal without complication, it must be tension-free, have adequate blood supply, receive adequate nutrition, and should be free of sepsis. As Sir have told earlier, a recent meta-analysis revealed that a stapled ileocolic anastomosis have fewer leak rates than the hand-constructed ones. And fluid third spacing, tissue edema, and increased intraabdominal pressure secondary to the overzealous fluid administration will result in blood flow compromise in small vessels at the edge of anastomosis, and it interferes in healing. So, it is preferred to give under supplementation of fluids rather than overzealous fluids.
I think you brought out a very good point, Pavan. Hello, Pavan, are you there? Indraja?
Yes, sir.
What are the factors that I tell you when we what is called obligatory underhydration in the post-operative period? What are the advantages of that? Hello, talk. Hello.
Hello. Sir, I
The
didn't get.
answer is there on the slide, Indraja. Third point.
Sir, I didn't. Actually, my connection was disconnected. So
So what are when we
Yes,
do
sir.
obligatory underhydration in patients post-operatively,
Yes, sir.
what are the advantages? I've told you so many times. Anyway,
we understand the question, Indraja.
Yes, sir.
What
I
was
will
the
repeat.
Yes,
I will
sir.
repeat the answer. One is, if you underhydrate the patients, because there is all the other, the ADH and other things are working, you don't have to give them so much fluid. It
Yes,
will prevent fluid accumulating in the interstitial spaces of the lungs and
Yes.
help the patient breathe easier, so they won't develop post-operative atelectasis and pneumonia and other conditions. Second is, if there is no excessive fluid, then there will be no peripheral edema of the legs and things which will hamper their mobility and their early mobilization from the bed. And third thing is, there is no ileus or intestinal edema, and anastomosis is not at risk because of the subliminal compartment syndrome like picture, or edema of the bowel, and that becomes that leads to paralytic ileus and things like that. So basically, you have to give them only as little amount of fluid as is necessary to have maintain a blood pressure and maintain an urine output, as we know, 0.5 ml per kg per hour. Okay.
Yes, sir.
Okay, I think this is just a digression from the topic. Carry on.
Sir,
Yes.
if I may.
Yes.
Just one point, quick point.
Yeah.
Praveen.
Sir, yes, sir.
when you're making a slide, here in
Yes.
the second point you've written recent meta-analysis, but your reference say that it is a systematic review. Okay, there is actually a difference between the two. Point one. Second thing, you said it is recent, but here you can see both your references are in 2007, 2009. So
Not recent.
Yes, sir.
yeah, they're not recent. So that is one thing.
Yes.
And
Yes,
just
sir.
to add on to what Ravi Shankar sir said, that obligatory underhydration, it is a component of ERAS. Okay, we, as most of us, we only understand the post-operative part of ERAS, which is give early liquids, make the patient no opioids, no catheter and all. Please go read up. There are 27 components, of which underhydration is one of the components in it, with daily weighing of the patient's weight.
Yes. Okay. Carry on.
Yes, sir.
Ravi.
Fetal wound healing.
Not fatal, man. It's
How
fetal.
fetal, sir.
Ah.
Fetal wound healing and how this differs from the normal wound healing is its characteristic is its lack of scar formation, and the factors influencing our wound environment. As fetus is in sterile and temperature stable fluid environment, it favors the lack of scar formation. And in fetus, as the immune system is underdeveloped and there are fetus is generally neutropenic, so the inflammation is very less compared to adults, and growth factors and mainly of tissue growth factor beta. This tissue growth factor beta is the main reason for the formation of scar, uh, which is relatively less in fetus. And how can we use this point is like tissue growth factor beta 1 and beta 2 is downregulated by tissue growth factor beta 3. By using of this tissue growth factor beta 3 isoforms, by application to the adults, we can reduce the scar formation. And wound matrix. Fetal wound matrix has high level of hyaluronic acid, which favors the lack of scar formation. And by this, we can also use the hyaluronic acid topically to prevent the scar formation and adhesion formation. And there is a transition wound which occurs around third trimester, in which it is there is a lack of scar formation in the fetus, but there won't be any regeneration of the skin appendages. And after this transition wound, adult wound formation occurs. And types of wound healing. It is of three types. Primary intention. It resembles when during the wound, when the both ends of wounds are approximated by suture, it is primary intention. And in secondary intention, the wound is left open to form the granulation tissue. And in tertiary intention, which is also a delayed primary closure, initially we leave the wound open to form the granulation tissue, and later we will approximate by suture.
Praveen, 1 second.
Now,
Can you come back one slide back? What is the difference between secondary and tertiary intention if both have granulation tissue? What if you suture a secondary intention wound? Will it become a tertiary intention?
sir,
Did you understand my question?
yes, sir.
Do you know
In
the
secondary, sir.
No, go on. You were saying something.
In secondary intention, the wound is healed completely by the granulation tissue, and there will be epithelial formation. But in tertiary intention, it along with granulation tissue, the wound is closed by contraction, and there won't be any epithelial formation.
Okay. Now, what I'm saying is in secondary, if I suture it, it will be the same.
Sir, in secondary intention, we can't approximate the edges.
What if I can? I'll raise flaps and approximate. What will it become? Will it become tertiary intention then? Okay, in simple, I'm asking you guys, what is the difference between secondary intention and delayed primary closure? Or in which cases do you do a delayed primary closure?
I think you'll have to tell them. They probably don't know.
See, primary is a clean incised wound which you suture immediately. Sometimes in a patient of RT or something, if you get a very contaminated wound, you don't want to suture it immediately. You leave it open, you give it a thorough wash, and you wait for a few days for the edema to resolve, and then you go back and suture. That becomes a delayed primary closure. And whatever you said, no, where you allow the granulation tissue to form and then for it to heal, that is called as secondary intention. So you wait for the edema and contamination to come down in a delayed primary closure.
Yes, sir.
Okay, carry on.
Sir. Usually in regular wounds, the maximal wound strength will be only 75 to 80%, which is reached after 6 weeks. There won't be complete regaining of wound strength. But in conditions such as nutritional deficiencies, infections, and if there is severe trauma, there will be delayed healing. But when these issues are resolved, the healing will be parallel to the normal healing and almost completes along with the normal healing. But when conditions such as compromised immune system, patients of diabetes, and when there is chronic steroid usage, there will be impaired healing, and the wound won't gain the strength, mechanical strength. And factors that are affecting wound healing can be classified into systemic and local. The main factors affecting the wound healing is hypoxia, anemia, and hypoperfusion. Because for the main basis of wound healing is production of collagen synthesis. And for production of collagen synthesis, oxygen acts as cofactor in its hydroxylation steps. So for a better wound healing, we can increase the subcutaneous oxygen tension by increasing the FiO2 of inspired air for a brief period during and immediately after the surgery. By doing this, it enhances the collagen deposition and decreases the rate of wound infection. Steroids. Larger doses or chronic use of steroids reduces the collagen synthesis and wound strength by mainly inhibiting the inflammatory phase, and it also inhibits the epithelialization and contraction, and it also increases the rate of wound infection. We can counteract the effects of steroids by topical application of vitamin A. Metabolic disorders such as uncontrolled diabetes, in which there is reduced inflammation, reduced angiogenesis and collagen synthesis. Uremia, in which there is abnormal deposition of calcium and phosphate in tissue leading to gangrene syndrome. Obesity. Obesity is a major factor affecting recently in the wound healing, which and the perioperative complications includes wound dehiscence, surgical site infection, incisional hernias, seromas, hematomas, and fat necrosis. Nutrition. In patients ill patients, by dietary supplementation of arginine, beta-hydroxy beta-methyl butyrate, glutamine, it enhances the collagen deposition. Vitamin C. The deficiency of vitamin C can be seen in defect in wound healing because it increases the incidence of wound infection by impairing the neutrophil function and decreases the complement activity. So, in patients with deficient vitamin C, recommended dosage of allowance is 60 milligrams daily. But if patients are severely injured or there is extensively burned patients, we can give up to 2 grams daily. Vitamin A. It increases the inflammatory response. As I said earlier, it reverses the inhibitory effect of corticosteroids and wound healing, and it can also be used to restore wound healing in patients of diabetes and patients having cyclophosphamide as treatment, and patients exposed to radiation. And we can give supplement dose of 25,000 to 1 lakh international units per day. Deficiency of zinc causes decrease in fibroblast proliferation, which results in decrease in collagen synthesis, and there will be a delayed epithelialization. Infection. The most common organisms seen at the wound site are Staphylococcus species, Coagulus negative Streptococcus, Enterococci, E. coli. And most surgical infections occur within 7 to 10 days post-operatively. And we can classify the wounds according to the infection rates by clean wound, in which there is clean incised wound, such as thyroid breast surgery, in which infection rates we expected after surgery is only 1 to 2%. Clean contaminated wound, in which there will be no inflammation, such as in elective cholecystectomy, elective appendicectomy, in which the infection rate expected is 2 to 9.5%. In contaminated wound, in which there will be inflammation, but it is non-purulent one, in cases such as emergency cholecystectomy, appendicectomy, and in which infection rate is around 3.4 to 13.2%. And dirty infected wound, there will be a purulent discharge, such as in cases in abscess, peritonitis, in which fecal contamination is seen. And if there is neglected traumatic wound around 6 to hours, traumatic wound greater than 6 hours, in which there is high infection rate around 3.1 to 12.8%. We can decrease this infection rates by treating the patients preoperatively by antibiotics.
Ravi,
Sir,
if you look at your wound infection rates, contaminated and dirty infected wounds is almost similar. In fact, the contaminated wound is much worse than the dirty wounds.
yes, sir.
I think I'm not sure your rates are correct. I think that the dirty wound purulent discharge, I think the infection rate is up to 40%. I don't know where you got those figures from. Nishant, what do you say?
I agree with you, sir.
I think all other figures are correct, but the dirty infected wound, the discharge rates are higher. The infection rates are higher, up to 40%. Just go and check
Yes,
that.
sir. Yes, sir.
Okay.
Yes, sir.
Yeah.
I'll confirm it, sir. I'll correct it,
Okay.
sir. Yes,
Okay.
sir.
Continue.
And we can decrease this infection by antimicrobial prophylaxis before surgery. And other side of healing is excessive healing. Clinically, you can see this in skin by mutilating or debilitating scars and burn contractions, in gastrointestinal system as strictures or stenosis, in organs such as cirrhosis, pulmonary fibrosis, in peritoneal cavities such as adhesions, in tendons such as frozen repairs. In skin, it is exhibited as hypertrophic scars and keloids. The difference between
contracture, not contraction. Contracture.
Yes, sir.
Okay, right.
The difference between hypertrophic scars and keloids are, in hypertrophic scars, the excessive growth will rise above the skin, but it will be confined to the original wound site and it will regress over time. But in keloids, it rises above the skin, but it will extend beyond the border of original wound and it rarely regresses spontaneously. And you can see the difference of keloid and hypertrophy scar, in which initially the patient may be symptom free, but keloid may appear years after injury. But in hypertrophic scars, it occurs initially only in the 4 to 6 weeks post injury. And keloids, there will be no spontaneous regression, but in hypertrophic scars, we can expect frequent spontaneous regression. How to prevent this keloids and hypertrophic scars? We can prevent by silicone sheeting, post-surgical intralesional corticosteroid injection, that is triamcinolone acetonide 10 to 40 mg per ml at 6 weeks intervals, post-surgical topical imiquimod 5% cream, post-surgical fluorouracil pulse dye lasers. And for first line treatment, we can do cryotherapy, intralesional corticosteroid injection, silicone elastomer
One
sheeting.
second, I'm sorry. Can you
Yes,
just go
sir.
back one slide? So all your whatever measures you have told, are you going to do this for all the patients? Because it's prevention.
Sir, in patients where we can expect hypertrophic scars such as large wounds,
No, basically, if they've had a previous surgery and they already are prone for keloids and all, for them, these can be tried. Okay, so you don't have to do
yes,
this
sir.
routinely for everyone.
Correct.
Yes, sir. For first line treatment, we can apply cryotherapy, intralesional corticosteroid injection, silicone elastomer sheeting, pressure dressing with pressure of 24 to 30 mm Hg for 6 to 12 months, surgical excision, and combined cryotherapy and steroid injection, and triple keloid therapy, which includes surgery, corticosteroids, and silicone sheeting. And second line and alternative treatment is verapamil, fluorouracil, bleomycin tattooing, post-surgical interferon alpha 2b radiation therapy.
One second.
Peritoneal.
Praveen, just one. I'm sorry, I'm disturbing. Just one
Yes, sir.
second. When you meant surgical excision, see, the whole idea of the keloid forming is because of some sort of surgical procedure.
Yes, sir.
On top of that, if you do another surgery for it, won't you have a bigger keloid?
So, the excessive scar tissue will be removed and we can do
saying.
preventive treatments, sir.
First time without doing anything, only you got a keloid with just a single
Yes, sir.
incision. Now, if you
Yes,
make
sir.
such a big raw wound, won't they have another bigger keloid?
So we can prevent by giving the preventive treatments, sir.
No, the thing is, it's called intralesional surgical excision. You don't go beyond the borders of the keloid.
Yes, sir.
Okay, so that is something that you need to know. And the same applies for all the PGs also. It's called intralesional excision. Please go read up about it. Carry on, Praveen.
Yes, sir. Peritoneal scarring. Peritoneal scarring means it is fibrous bands of tissue which are formed between organs that are normally separated. It may be formed due to damage occurring during surgery, thermal or ischemic injury, due to inflammation, due to foreign body reaction. This injury stimulates the inflammatory response, leading to hyperemia, fluid exudation, activation of coagulation and complement cascade. Two major strategies for this prevention are by surgically, we can minimize the surgical trauma by careful tissue handling, avoiding desiccation and ischemia, and spare use of cautery, lasers, and retractors. And other method is barriers membranes and gels. It includes Interseed, Ceprafilm, and Adapt.
Has any of these been helpful, Praveen? Using Ceprafilm and Adapt? See, I think one important thing that you forgot to mention, anybody? See, by reducing the surgical trauma, what does he mean? Anybody? Praveen, sorry, Pavan.
Sir.
Pavan?
Minimal invasive surgery, sir.
Correct. So, if you see the incidence of adhesions, post-operative adhesive obstruction and complications thereof are much less in minimally invasive laparoscopic surgery compared to open surgery. So, whenever possible, do laparoscopic surgery, which will reduce for example, if you go back for whatever reason, if you go back into these abdomens that have had laparoscopic cholecystectomy or appendicectomy or any other surgery, the chances of you finding adhesions are much less compared to an open operation. It's not that it doesn't happen, it is much less. Other thing is, for example, the newer, whatever the so-called the newer meshes that they recommended, including the Sepra film on one side. What do they call the new meshes? Very expensive meshes. The incidence of incidence of adhesion, fistula formation, and all the complications relating to that is similar. In both using a Prolene mesh or one of these super meshes as they are called. So I don't think this. And I was part of the study when we were in England. When I was in England, looking at usage of Sepra films in the post-operative, using Sepra films, prophylactically to prevent adhesions, and using Adept solution, which is a liquid form of Sepra film, and basically it had never helped, never seemed to help. A nationwide study was conducted, and the incidence of adhesions and the two groups were similar. So none of these actually help. So basically, the important things to, as you said, is another thing that used to be very common, which is now not an issue, is the torque, which used to be used in the gloves. And so when you handle bubble and handle into the peritoneal cavity with gloved fingers, which contain torque, and that was seen to be causing more adhesions. And nowadays, most surgeons use torque without powderless gloves, and so that incidence is less. So infection, for example, if the patient has already got peritonitis or develops post-operative peritonitis, such patients will have higher chance of adhesions compared to people who don't have infection. Second thing is minimal handling of tissues, respect of tissues, minimal use of cautery, minimal use of other energy sources, and things like that. So and also maintaining oxygenation and normotension blood. If there is hypotension during surgery, again another possible source of adhesion formation. So all of these things you have to, and also basically wash after you have done surgery, especially if there is contamination. Wash the peritoneal cavity generously with saline, and then place the intestines in the normal order they are supposed to be, so as to prevent adhesive intestinal obstruction. Because even if adhesions develop, if they are in the adjacent and consecutive layers, it may not cause obstruction. If the bowel is placed in a haphazard fashion, for example, ileum over jejunum and things like that, then you can develop intestinal obstruction, because for obvious reasons. So you have to take all precautions to prevent it, because adhesive obstructions, once they happen, it's very difficult to treat. Nishant, anything to add?
No, sir, nothing to add, sir. You have covered everything.
Okay, carry on, Praveen.
Yes, sir. We have seen the anatomical, physiological, and pathological path of wounds. Now let's see the treatment of wounds. The management of acute wounds can be done by first examination. What is the depth and what are the underlying structures injured? Is there any non-viable tissue or no? And preparing the site of wound by anesthesia, and exploration by checking any underlying structures injured, and cleaning the wound site by betadine and saline. And approximation of wounds can be done if in deep layers, facial layers only are approximated, and it is preferably done by observable sutures. In superficial layers, it is done by non-observable sutures in skin, and we can use the staples, monofilament sutures, and dermal glues. And during the follow-up, we should check if there is any cellulitis of the wound or any drainage of pus from the wound. And normally suture removal can be done by 4 to 5 days for face and 7 to 10 days for other parts of skin. And the main purpose of dressing is to provide the ideal environment for wound healing. And what are the desired characters required for the wound dressing, sir? It must control the pain, control the odor, and it must be non-allergic and non-irritating. It must be non-traumatic removal. It should be cost-effective and convenience for the patients. And types of dressings are non-adherent fabrics. In absorptive dressings such as gauze, foams, in occlusive dressings such as films, hydrocolloids, alginates, hydrogels, and biologic homograft and xenograft. And um, other part of treatment of wounds are hyperbaric oxygen therapy. As I said initially earlier, oxygen is required as a cofactor for the collagen synthesis, which is the main process in the wound healing. So, in this hyperbaric oxygen therapy, it involves breathing nearly up to 100% oxygen intermittently under high pressure by a pressurized chamber. It is indicated in wounds such as clostridial myonecrosis, in crush injury, in radiation-induced soft tissue and bone necrosis, in necrotizing soft tissue infections, in diabetic ulcers, in refractory osteomyelitis, and in thermal burns. The other mode of wound healing is negative pressure assisted wound therapy. And the clinically benefits from this is it decreases the wound volume and size. It accelerates the wound bed preparation and accelerates the granulation tissue formation. Ultimately, it accelerates the wound healing. It also improves the rate of graft uptake, and it can cause enhancement of response to first line treatment of wound dressing. Yes, sir.
Okay. So I think he's covered most aspects of wound healing. Indraja and Pavan. Pavan, are you there or are you gone? Are you on call or something?
Sir, Pavan is on call, sir.
So has he gone to casualty or somewhere?
Maybe, sir.
He's not there. I think if you are going somewhere, please, at least type in the, in the chat box, because otherwise we won't know that you have left. As such, there are less number of people. And if you leave, then we will not know whom to ask questions. So please inform us. Okay, Indraja, what do you think of the class?
Sir, he presented well, sir. He covered everything, and his flow also is good, sir. And slides are also good. He explained everything, sir, in detail.
Abdul?
The class was good, sir. Slides were appropriate, no crowding. Some slides here and there at the end where there was some crowding, but otherwise, flow was good. He was not reading from the slides, I feel. And otherwise, it was done, sir. Very good for the first class.
Pooja?
Sir, he's covered most aspects, almost everything on wound and wound healing, sir. The presentation was good.
Praveen, can I ask you whom you got the help of to form, make the slides and things?
Yes, sir. Indraja ma'am, sir.
So if there is any fault, then we have to punish Indraja.
No, sir.
She's the teacher. No. I'm just, I think, Nishant, your comments, please.
Praveen, very well done.
Sir.
Thank
you, sir.
Good slides. You have covered a lot of information. I've even read up about it. If I have to need to pick only one thing, when you have headings like dressings or wound healing or something like that, don't read it out. You're saying dressings and then again reading out the next point. So don't, because it's there. We all know that you want to talk about dressings. That one thing you learn as and when you present. So you don't have to keep stressing out that heading again and again. Otherwise, it was a very good class. Even I learned a lot. It was like a revision of all our general surgery topics.
Yes, sir.
Good.
Thank you, sir.
Praveen, I think I have to tell you, first thing I have to tell you is it didn't appear like your first class. I think you have done exceptionally well. You presented well. The important thing is you didn't, as Abdul said, you didn't read out the slides. I think you seem to have prepared well for it. You have read the cross references and you were able to explain what was there. As Nishant said, you don't have to read out, but that is
Yes,
a
sir.
common mistake everybody does. You just have to improve on that. You don't, it
Yes,
is
sir.
there, the heading is there. So you just say, if you really want to say coming to wound healing, add something so that it doesn't appear as if you're just, like a, parrot, you're saying wound healing or whatever the heading is. So if you
Yes,
you
sir.
can use the flow of the presentation to overcome such thing, but you will learn as you go along. I think
Yes, sir.
you prepared well, your slides were good, and the small, here and there, some slides were crowded, but you will again improve as you go along. I think the
Yes, sir.
important thing is, you started well, keep up the standards or improve on them regularly, and
Yes.
also, do this one, what we call as the, not just a textbook reading, you have to use journals and, other references, so that it becomes more postgraduate level of subject seminar rather than an undergraduate level of subject seminar. Well done.
Yes, sir.
I have to say that I learned a lot. It was good. Okay, so if there are
Yes,
no
sir.
further
Thank you, sir.
questions, we will conclude the class. Good night to everybody. Good night.
Thank you, sir. Good night.
Good
Thank you,
night.
sir. Good night,
Good
sir.
night, sir.
With everyone.